I think this is at the moment the most favored field in which I am involved, which is very peculiar for a neuro-oncologist, because people tend to think that we are in charge of treating primary brain tumors, but this is not true. I think that the most exciting developments in terms of prognosis following treatment are now in brain mets. In some molecular subgroups of non-small cell lung cancer, breast cancer, and melanoma. For instance, non-small cell lung cancer has two molecular subgroups, EGFR mutated tumors and ALK rearranged tumors. And the interesting thing is that we have now at least 3 lines of specific inhibitors targeting specific with mutations, and these inhibitors are active both in the primary tumor and in the brain mets. Just to give you an idea, in ALK rearranged non-small cell lung tumors, brain mets, now the overall survival of brain mets, whatever treated, local treatment, systemic treatment, is around 4 to 5 years. So 10 years ago it was 6 months. So I think this is the major advantage, and we have similar findings in HER2 positive breast cancer, BRAF mutated melanomas, and very, very exciting. Basically, I think we have 3 major problems. Obviously, 3 major biological problems. But we have to face with them unless we will not improve our therapeutic possibilities. The first one is the heterogeneity of tumors, which means in some areas there are some mutations, in other areas different mutations, and both in primary and secondary brain tumor. For instance, in brain mets, at least 50% of the mutation of the brain mets is not present in the primary tumors, which means that we should need tissue of the brain mets to tailor the treatment, not to tailor based on the primary tumors, because we have a 50% probability of failure. And the second problem, I told you again, especially in primary brain tumors, we lack driver mutation. Driver mutation means mutations that are critical for tumor growth. So the tumor has a million of mutations, most of them as useless, at least for treatment. Probably very useful for the tumor, but not for us. And the last problem is that when we work with target molecular agents, most of these agents are either antibodies, very big molecules, problematic to cross a normal blood-brain barrier, or small molecules, but again, the penetration of the normal blood-brain barrier is very critical and debatable. And I think this is very critical because obviously when the blood-brain barrier is normal, our treatment should be a preventive treatment, and hopefully prevention is better than treatment.